Hello and welcome to COVID-19, Keeping Up with the Moving Target. I am your moderator, Faith Rogers with DKB Med. Thank you for joining us. We are pleased to introduce our expert faculty member, Dr. Paul Auwaerter, Clinical Director of Infectious Diseases at Johns Hopkins School of Medicine. Dr. Auwaerter, thank you so much for your time.
Thank you, Faith. Delighted to be here today with you all.
Thank you. And these are Dr. Auwaerter's disclosures. This educational activity is supported by independent educational grants from Gilead Sciences Incorporated, Regeneron Pharmaceuticals Incorporated, and Eli Lilly and Company. Please note that this material presented is current as of today. That's June 9th of 2021. Please do consult NIH and IDSA guidelines for the most current guidelines. As for our learning objectives, today they are to appraise the efficacy, safety, and indications for treatments for patients with COVID that require hospitalization, evaluate management strategies for outpatients with mild to moderate COVID-19, explain mechanisms of action of monoclonal antibodies and other current and in development treatments for COVID, and describe the best practices for managing patients with COVID with monoclonal antibodies and other agents. With that, I would like to welcome Dr. Auwaerter to begin the presentation. Thank you so much again.
Okay, thank you, Faith. And again, I want to welcome everyone and glad that you're joining today's webinar. So much in COVID-19, we've been through quite a bit in the past 16 plus months. Not only has there been great stresses on healthcare systems and our patients and families, but the approaches to this continue to evolve, and I'll try to do my best to bring you up to date. I think many of us are familiar with COVID-19, and largely this viral infection is mild for many people, but about 20% can develop a severe COVID-19 that's going to be bad enough that pneumonia or organ dysfunction, especially in the lung, lands someone in the hospital. Now, if the younger you are, you're less likely to fit these percentages, but even young people, there's a substantial portion of even 20-year-olds and 30-year-olds that can land in the hospital, especially if they have comorbidities. This is a fascinating virus that's really, I think, different than others in that there's an early typical viral-like illness, a lot like influenza, early on, but then in a subset of people for which we don't quite yet fully understand the reasons, some trigger a rather dramatic inflammatory response, which seems to drive much of the organ dysfunction as well as a potentially lung injury in ARDS, which I think is amongst the most feared complications and one of the reasons people stay in the hospital for extraordinary lengths of time or unfortunately succumb along with multi-organ problems. Now, who's at risk? Anyone, even healthy people, can develop severe disease, but it's become clear that if you look at the left column, a number of observational studies have really highlighted these conditions that appear to drive people more likely to have a higher percentage risk for developing severe COVID-19. And that includes obesity, and that's really a BMI of 30 or more, along with diabetes, heart and lung disease, active cancers, and renal disease. Interestingly, areas which are a bit unclear and I think continue to cause confusion is down in the right-hand part of this slide with mixed evidence, where you have hypertension listed. You might remember this was often lumped in early on, but I'd have to say hypertension alone probably is not a strong risk factor for severe disease. Of course, in the middle is probably less robust data, but certainly I have concerns if patients have any of these conditions and develop symptoms consistent with COVID-19. Now, these are all medical conditions, and I want to emphasize there's a really clear age gradient. The older you are, the higher the risk for dying. People over 85 are especially at risk, but those really over 55 to 65 pose special risks. But then certain demographics, including race and ethnicity, at least in the United States and really elsewhere in other countries, there are certain groups that seem to be more prone. And this is probably due more to socioeconomic factors and underlying health conditions, but it's also possible there are other factors. But what you can see here especially are that Latinx or Black patients are at higher risk for hospitalization or death. And this also includes smaller groups such as Native Americans or Alaskans. So I think these are people that we also try to closely follow. And I honestly try to educate people with these healthcare problems to try to call and seek diagnosis early, because that gives us a better chance for mitigating severe illness. So this is a bit about therapeutics. And the ambulatory patients are where you would hope to have interventions. And we do have treatments for our outpatients, but it's limited at this stage. And we really don't yet have an oral antiviral like oseltamivir for influenza. But when patients are at home, if symptoms develop, there's still advice here that we need to follow. So for people who have COVID-19, I think there's been some decrease in taking care not to infect others, but isolation is still key for at least 10 days, unless if someone is immunosuppressed, in which case we extend that further to 21 days. Quarantine also if you have a close contact, but testing is an avenue to try to get out of jail, as it were, early. So if you do testing, you can actually shorten the time in quarantine. But as the numbers diminish, and I think we're trying to really limit, there may be a return to some contact tracing and trying to identify cases here. You know, there are concerns about variant viruses, and I think some people feel they may not be at risk in many parts of the country, especially where immunization rates may not be that high. So this, I think, remains something that's very important, and to try to help counsel your patients. But the only currently available therapies are investigational monoclonals that have Food and Drug Administration approval under emergency use. But these have really made an impact. I'd like to sort of tell you that story and where we are with that. Now, you might remember the first one available was a single monoclonal called bamlanivimab. That's no longer used, and it's been complexed with a second monoclonal called etesivimab. These two antibodies are targeting aspects of the spike protein of the coronavirus. And this trial published earlier in January suggested a marked reduction in patients that have those risk factors that we just reviewed. You can see nearly a 90% risk if they got the infusion for avoiding hospitalization or death. So again, probably you want to try to infuse this if you can earlier in illness, ideally less than 3 to 4 days if you can, but you can give these medications up to 10 days, but probably later on, you know, if you're at day 5, 6, 7, your body's own immune system's kicking in, and there's probably less opportunity to try to stave off the virus triggering that severe illness with those inflammatory responses. So this is given by IV infusion, and you do have to get it generally at certain centers. This is not universally available. You cannot, you know, call your druggist and administer it. The second one that is also available is casirivimab and indivimab. This combination cocktail is the one that the president got back in October. But this trial here, again, is in the outpatient population, many of whom had risk factors, and also was a heavily Hispanic segment to the population here, and did reduce symptoms. And you can see here, again, a very potent risk reduction again for hospitalization or death. And it included this lower 1,200 milligram dose where you get 600 milligrams of each monoclonal infused intravenously. So this lower dose is the one just earlier last week that the Food and Drug Administration authorized the lower dose instead of the higher dose. And the second thing, which I found very interesting, is that they also have said that the doses could be given subcutaneously if not given IV. We've known for years when we try to treat people with hypogammaglobulinemia that we can give immunoglobulins subcutaneously. And of course, the IV infusion is more cumbersome and can't be given in offices and so on as easily. So the sub-Q route is one that I bet will be increasingly adopted, although for the moment it's only if you cannot give an IV infusion. Now there's a third monoclonal that was just given authorization in May called Cetrovimab. This is just a single monoclonal antibody. And this again was tested in a very similar way for patients who are outpatients with mild COVID-19. And they got these intravenous infusion, and you can see, again, very similar 85% risk reduction for either needing to go to the hospital or dying. So this particular antibody probably is not yet widely available, but since it was just authorized a couple weeks ago, this also may be another one. Now, most centers are not giving people a choice of which to give for the moment, but there are some other nuances that we'll talk about. But I think you get the sense that they all equally work well to try to keep people out of the hospital and therefore protected. One of the stories which I think is continuing to evolve would be the effect of the variants of concern, which we began hearing about last fall, but appear to have a particular impact on these monoclonal antibodies, in part because many of them are targeting different aspects of the spike protein from a genetic sequence that was isolated over a year ago, and of course the virus has evolved. What we've seen, and these are so-called pseudo-neutralization assays, that if you have a value of more than 1,000, it means from this in vitro assay that it's highly unlikely the antibody will work to protect patients. So many weeks ago, this information came out against the alpha, beta, and gamma, whereby bamlanivimab as a single monoclonal really was no longer distributed. These monoclonals are given free of charge through the federal government and HHS. So this was no longer distributed, but this was around the same time that the combination with etesevimab was authorized. You can see that so far, casirivimab, indivimab, and Cetrovimab look to be very effective still against these variants in this sort of assay. The bamlanivimab, etesevimab, you can see is losing some potency against especially the variants that have been more problematic, such as beta and gamma. You know, these were first identified in South Africa and Brazil. So for that reason, currently HHS says that you should not use that particular combination in states where more than 10% of cases are due to beta or gamma isolates. The beta and gamma is a new designation by the WHO to try to get out of the numerical soup designation. Now, who can get it for the moment? Remember, it's only outpatients with mild to moderate disease. They can be 12 or older. And I've mentioned within 10 days of illness onset, but functionally, I'd say before day 5 to 6 is really what you want to target for, and earlier the better. And they need to have risk factors that we discussed for severe COVID-19 complications. And the criteria here is evolved a little bit to expand the list. In part, I think as numbers have come down and these monoclonals are more widely available, they're not so much now a scarce resource. There's been some liberalization, so the highest risk people no longer are the only ones eligible. You can see here it's been spread out a bit to others that also have risks. And I would encourage you to toggle on the link, but most referral centers will have these forms, and you can you need to know how to do this within your own state. So you can usually look this up on the state or local health department COVID-19 website to find referral centers, and it's relatively easy to do, and I very much encourage you to consider that for your patients at high risk. And again, these are the only antiviral therapies we have for outpatients, but they are highly effective and they're reproducible. The trials all show this rather significant 70 to 85% reduction in the need for hospitalization or dying. And I'm hoping that people get diagnosed early, because the early diagnosis and referral is really where these shine. These monoclonals haven't worked as well in hospitalized patients, in part probably because patients are presenting later at day 7, 8, and 9 for hospitalization during the hyperinflammatory phase. You won't have much impact for the monoclonals at that stage, so many of the trials have been either halted, although some are ongoing in select patients, so we may hear more about this down the line. Both the National Institutes of Health and the Infectious Disease Society of America have backed using monoclonal antibodies. So I think that's important. Not everyone's incorporated the Cetrovimab data yet. And I've already mentioned the caveat about not using the one combination product, the bamlanivimab and etesevimab, in states or locations where you have a higher percentage of certain variants. Lastly, I'll mention an area that I think for many of us that take care of immunosuppressed patients may have value. You know, these are patients that often worry, did they respond to a vaccine? Am I protected? And so on. And these monoclonal antibodies have been tested for prevention in certain settings, such as nursing homes or in household members who have been exposed. And although bamlanivimab probably won't be used moving ahead, these two studies show proof of concept that these antibodies can work to help prevent illness. So here you have a subcutaneous injection that had an 80% prevention rate through day 9. And you can imagine people that at high risk who may have been exposed or who have ongoing exposure risks. This may be one avenue, especially in people that don't respond well to vaccines, such as people that are on rituximab and so on. There are no other outpatient treatments currently authorized, and of course there's been a whole host of medications such as hydroxychloroquine and azithromycin and so on, ivermectin, who have all had their proponents, but really haven't yet had studies backing use to a large degree. I did want to mention these two trials using inhaled budesonide and inhaled steroid, two trials that seem to suggest treatment in outpatients led to less hospitalization or need for care or a shorter duration of illness. The reason I bring this up, of course, are in areas elsewhere where there have been resource constraints, such as in India. This may not yet be ready with a robust prospective phase 3 trial, but given the difficulties of getting medical care, there may be indeed potential for this sort of inhaled steroid to work, whether it quells inflammation. There's also some thought it may inhibit binding of the virus to cells. So I think this is something we'll stay tuned for. I'd like to just talk about hospitalized patients. This is where there was so much focus early on because, of course, these were people who were presenting. Now, early in the pandemic, I would say people presented rather late, and often treatments had a harder time showing benefit. But I think people are now coming into hospital earlier, and we'll go over some of the treatments. And of course, the first one that many people are familiar with that was given EUA approval and is the only one now fully approved by the Food and Drug Administration for COVID-19 is Remdesivir. This is a repurposed antiviral. It's actually a prodrug originally developed for hepatitis C. It's been used in Ebola. That needs to be metabolized, but it works by inhibiting the RNA polymerase for making new subgenomic RNAs that can then be translated into proteins to assemble new virus. So, certainly useful in concept. And the first trial that used it was a placebo-controlled trial, Act 1, that was sponsored by the NIH. And this trial, I think, it was well done, had a primary endpoint, meaning time to recovery. And there was a 5-day difference there that was statistically significant. I think at times where hospital beds were full, this was very meaningful that you had a 5-day difference, 5 days recovery. Now, this was early in the pandemic. The trial was not large enough to show mortality benefits, although there was a trend. But yet there was criticism that this drug doesn't save lives. And indeed, the WHO Solidarity trial, which we can talk about in the question and answer if you wish, didn't have a mortality benefit. And I think people have some different opinions about Remdesivir. But if you look at this Act 1 trial, I think it clearly showed a benefit in terms of people that recovered faster than if they didn't get the drug. And then, importantly, if you actually look at who drove this improvement, it was the people that were receiving oxygen, not the people that didn't need oxygen or, as you'll see, in the ICU. So these were people that were probably on the hospital floor. They needed 2 or 4 liters of oxygen. So this was, and also the largest group of people that seemed to suggest benefit and probably drove that primary outcome. Now, patients that were started on Remdesivir later in the ICU had less benefit. And I think this is expected, where probably shutting down replicating virus is less important in this hyperinflammatory phase. Now, from a safety perspective, I think it's a fairly safe drug. In fact, in the trials, you could see people that got Remdesivir actually had fewer adverse events than placebo, which probably means it's helping treat the illness. And so both the NIH and the IDSA continue to endorse use of Remdesivir in COVID-19 for people in the hospital because it is an IV drug, and those who need oxygen. So not people that don't, or, and as the NIH said, not for people that are already in the ICU or ECMO. Now, the IDSA says you can use it in the ICU, but I think there's less robust evidence there to suggest benefit. And I think probably most use it for patients earlier in their illness that are admitted to hospital, but not yet in the ICU. Now, I've already hinted at that we only have IV or sub-Q monoclonal antibodies for outpatients. What we're really missing are oral antivirals. There are 2 that are in trials now, one further along called molnupiravir. That's a twice-daily drug that is inhibiting the same RNA polymerase as the Remdesivir. And phase 2 trial information was presented back in March that showed that the drug really suppressed viral shedding by day 5 of illness, as you can see here. We're waiting for phase 3 trial information to see if it's really improving clinical outcomes. Another drug, which continues to just go by its name, AT527, works similarly and is thought to be even a little more potent, but is not yet as far along in its clinical trials. So hopefully these drugs will have clinical benefit and give people that are in the outpatient arena an additional option. Now, for hospitalized patients, convalescent plasma was used pretty liberally last year. The idea was to try to directly neutralize virus, hopefully, but maybe it also provided some immunomodulation. And was used very widely last summer and through the fall. But then some information came out whereby the FDA revised its emergency use authorization such that units only with high titers against the coronavirus could be used. And this is important because many people that were donating even after recovery from COVID really didn't have abundant antibodies in their serum. There are lots of trials about plasma and lots of opinions about it. I would say this information that came from that expanded access program in the United States last summer sort of helped clarify a bit where this could help. And these were people that, a subset of the over 35,000 people at this point that got plasma, about 3,000 where they had titer information. And what this graph shows are that the high titer people who got convalescent plasma before they were in the ICU appeared to benefit. So again, early treatment with higher amounts of antibodies that could bind the virus may indeed help reduce severe disease and death. Now, this was a retrospective aspect. There was no control arm, so those are legitimate criticisms. But much like the monoclonal antibodies, to no surprise, if you used high titer convalescent plasma in outpatients, and this is a where you had to be 65 or older, so the groups that were really at high risk for severe COVID-19 did benefit with reduction in proceeding to severe COVID-19 if they got convalescent plasma before 3 days of symptoms had elapsed. So again, if you have patients in hospital that are in the early phase of illness, we can't use monoclonal antibodies, but convalescent plasma potentially could help blunt progression to severe illness. Now, looking at the totality of these convalescent plasma studies, these plots are not terribly encouraging. You can see there's wide variances. Many were stopped early because there weren't enough patients to enroll. But by and large, it's not an impressive story for convalescent plasma. But I think a lot of this is because patients were getting plasma, like the recovery trial, the largest one, they got it at day 9, instead of day 3, 4, or 5. So again, it's probably not for every hospitalized patient, but there are those that I think benefit. And these kinds of trials, and this is just another plot, instead of looking at mortality, looking at progression to mechanical ventilation, which shows a trend, but not, again, statistically significant for benefit. So currently, I'd have to say the NIH and IDSA are not endorsing use of convalescent plasma. However, I think looking at the positive trials, my advice is if someone's early in illness and hospitalized, convalescent plasma may be useful. And the second is there are people that are quite immune suppressed, and we've used quite a bit of it in the hospital for solid organ transplants, people who don't make good antibody responses to vaccines because they're on immunosuppressed drugs or have active malignancies. So this is where I think convalescent plasma may still have a role. Now, the immunomodulatory agents are important, especially for our more severely ill patients. And much to the surprise of many, a steroid, dexamethasone, really helped patients who were severely ill in the ICU. And this is contrary to a lot of prior ARDS trials with steroids. But with this monomorphic illness with the virus, I think the coronavirus does trigger this very broad inflammatory response. And dexamethasone led to a mortality benefit you can see here if you were ventilated from over 40% to 30%. And even if you're on oxygen, but not in the ICU, you had a smaller benefit, but meaningful. Interestingly, if you didn't need oxygen, there was a trend towards worse outcomes. So you really don't want to use dexamethasone until you're pretty certain your patients are heading into that hyperinflammatory phase. So typically oxygen requiring and with increasing oxygen requirements. So this was really the first drug to show a mortality benefit. It was done in the United Kingdom, which had much higher rates of mortality than in the United States, but really has been adopted as a standard of care by many in the United States for hospitalized patients. Now, there is a story about Tocilizumab. This is a monoclonal antibody that inhibits an interleukin-6 receptor. And you may remember back, February of 2020, the Chinese guidelines for COVID said this is a possible treatment. And it was, I think, picked up because of this cytokine-like release syndrome, where this drug is actually approved by the FDA in oncology for so-called CAR T-cell therapy that stimulates a cytokine release syndrome. So early on, many centers use this. We used it at Johns Hopkins on the premise that it might help mitigate that severe inflammatory response and get people out of the ICU and off the ventilator. However, this graph, this table, I should say, shows trials, the first 4 of which used it as monotherapy, and they were all negative trials, and the drug fell out of favor. But then last fall, the Impacted trial, the last one on the right, was a positive trial that suggested that people were less inclined to be in the ICU on a ventilator or die if they got Tocilizumab. And this was a larger trial, multinational, with many people of color. So this was interesting, and it wasn't exactly clear why this trial was different until you got to another trial called the REMAP-CAP that used Tocilizumab largely versus placebo. And much like the Impacted trial, at this point, the recovery trial that documented the use of dexamethasone showed that most people were on it and they got Tocilizumab to boot in this trial. And that was true in that Impacted trial. So largely people got Tocilizumab and dexamethasone. And what that showed is a really impressive 10-day improvement in the need for organ support, whether it was ventilation, renal support, or so on. And there was a mortality difference, nearly 36% down to 28%. So these two studies started to turn this tide, but then the larger recovery trial also incorporated Tocilizumab. And again, over 80% were on dexamethasone. And what they found was that there was a mortality benefit, decreased need to go to the ICU and be ventilated, and an earlier discharge. So again, these 3 trials, I think, convinced people that, especially with the weighting of the recovery trial, that there's benefit. And this meta-analysis, if you look at the line where were you on steroids, yes, you can see it clearly shifted to the left, favoring Tocilizumab, whereas if you didn't get it, it didn't. So it looks like the combination was clearly important. And if you look at all the studies, include the negative studies along with the recovery and so on, you can see that it still favors tocilizumab, most of that being driven by the larger studies that also had people on, mostly on dexamethasone. So the other drug, which has not been widely used, but baricitinib is a JAK1, JAK2 inhibitor, inhibits broadly inflammasomes, so a lot of inflammatory molecules that stimulate aspects of the immune system. And there have been 2 trials. The second one, called ACT2, showed about a 1-day improvement, so it really didn't generate a lot of excitement. People were better in 7 days instead of 8 days if they got baricitinib. But a more recent trial called the COVE barrier trial was a larger study where many people also were on steroids, about 80%, again, because the standard of care changed. And they were randomized to baricitinib or not. And there you can see there was a mortality benefit, although the primary endpoint, which was death or progression to increasing oxygenation, was not significant. So with this information in hand, I think the NIH said, look, if you have someone on dexamethasone and remdesivir, but they're getting worse, they're needing more oxygen, looks like they're heading to the ICU, you may want to use tocilizumab or baricitinib to see if you could sort of turn them around and avoid that terrible ICU illness or death. IDSA has something similar about tocilizumab, but they haven't yet updated to include baricitinib if they do. I think we're at Hopkins sticking with tocilizumab. The baricitinib trial, although I guess persuaded the NIH, we were a little less impressed with that trial and thought the 3 trials of tocilizumab favored use. The last immunomodulator, and again, this has not yet received emergency use authorization, but you may hear about it, is a monoclonal antibody that inhibits granulocyte macrophage stimulating factor called the Auwaerter trial. And in full disclosure, I was on the Data Safety Monitoring Board for this trial. But this trial was interesting in that if you looked at the modified intention to treat, there was benefit in terms of those who received the drug were less likely to need mechanical ventilation. That's the bars on the left. But for the groups that were not quite so super inflamed and not the advanced elderly, there was even a greater benefit. Probably people that got the drug earlier in illness rather than later illness, and had a survival benefit of 92% all the way over on the right, 92%. So this is something that I think the FDA will see. There are obviously no head-to-head comparisons of tocilizumab, this drug, or baricitinib. So it's a bit unclear how you would choose one over the other. And perhaps there'll be future trials trying to help study this. So we've covered a lot of ground, both outpatient and inpatient therapies. I'm hoping the take-home message for you are that the monoclonal antibodies, I think, are one of the most effective available for patients that really are at risk for bad outcomes. And that if you can get them diagnosed and in early, they're highly effective. We do have remdesivir, which is FDA approved for all patients, but the greatest benefit from the ACT1 trial were people on oxygen, but not yet in the ICU. And it did shorten the duration of illness by 5 days. And I think the idea here is that a shorter illness certainly is worthwhile for a drug that appears to be well tolerated. And lastly, dexamethasone is the one that's lowered mortality benefits. And I think we'll still have evolving data on the other immunomodulators, which aren't quite as well established yet, but more information and trials will be forthcoming as well. So I hope that was helpful, and it's back to Faith.
As a reminder, we're going to move into the Q&A now. So our first question today, Dr. Auwaerter, is, are people with HIV at higher risk for COVID-19?
So I think it depends. People that are just HIV positive but are on antiretrovirals with controlled virus probably are not at increased risk. Patients who are untreated, have advanced AIDS, who often have additional health problems probably are. So there's mixed evidence about that. It's not one of the ones that were in that left column there. And I think it depends on the stage of illness.
Okay, fantastic. Our next learner asks, is there any rationale for use of high-dose dexamethasone with a prolonged taper in patients with severe disease with a hyperinflammatory phase?
I think that's a interesting question. Certainly the dexamethasone is used at 6 milligrams. That was selected by Peter Horby and his group at the recovery trial. And people are pretty stuck with that, although other steroid trials against COVID have also been positive with use of hydrocortisone or methylprednisolone. The prolonged taper, I think, is tricky. Here's why, because there is a risk for secondary infections. And you have to wonder if the hyperinflammatory phase is that versus infection. The other aspect, I think, is also difficult. We've had some patients, 3 to 4 weeks into illness that seem to have this rebound, this sort of rebound hyperinflammation that we've sort of returned to steroid use when we felt pretty sure we've ruled out secondary infections. So I think there may be times where that's the right decision, but it requires pretty careful analysis. And of course, there's really no data to back that up.
Okay, great. Thank you. The next question is, some infectious disease specialists use azithromycin to help those with high symptom burden, but not on oxygen. Is there any data to support this use, as they say it acts as anti-inflammatory in this way?
Mm-hmm. Well, not that I'm aware of. Most of the azithromycin trials as an independent agent were done early on and were negative trials. The macrolide antibiotic can be an immunomodulator. I would not advocate its use for that. I think there are other drugs that have better activities. And so I would stick with some of the ones which we talked about today.
Very good. Which agents should we use, baricitinib or tocilizumab?
Yeah, I think this is personal preference. There's more data for tocilizumab. I think you really have to look at these trials and make your own judgments. The NIH guidance is really or. We have no head-to-head trials. If someone is not tolerating or can't receive dexamethasone, baricitinib is probably an option there, only because we do have trial information regarding that. Personally, I've sort of been sticking with tocilizumab, although I find the lenzilumab, the anti-GM-CSF antibody, also intriguing. It'll be interesting, and I think since they all have effects to differing degrees, there may be at some point head-to-head trials, but it could also boil down to cost and convenience as well. The baricitinib is an oral drug.
Okay. Thank you to everybody with these questions. We're getting so many, and I wanted to point out that if we do not get to yours today, we do have a weekly series where we have Dr. Auwaerter on, and he does answer questions at the conclusion of each of those. So stay tuned, and you may just see your question in another episode here. So the next question is asthma a chronic lung condition considered high risk for receiving monoclonal antibody?
I'd have to double check the fact sheet. Asthma really has mixed evidence currently for COVID-19. I know the FDA liberalized the number of indications for monoclonal antibodies. So I'd either have to get back to you or just simply check the fact sheets for any of the monoclonals to see if asthma is listed there.
Great, thank you. And also one more reminder to our learners, in the console on ON24, you should have access to the fact sheets on some of these monoclonal antibodies. So hopefully that can answer that question for you. The next question is, what are the side effects of Gcsf inhibition?
Well, the Gcsf is interesting because you're using a drug that's higher up in the and inhibiting more of the inflammation than you would, for example, with Tocilizumab. So maybe that's one reason it had perhaps a greater relative impact. The trials really were safe. And, at least through the 28 days, there appeared to be no increased risk of unusual side effects, including infections or clots. And it's really interesting that this is also held up with Tocilizumab and baricitinib, that these immunomodulators didn't seem to pose extra risk to patients in terms of superinfections. Although, please don't forget that the coronavirus itself, the rate of secondary infections with bacteria and fungal disease is rather significant regardless.
Okay. This question is, what is the Delta variant?
So the WHO is trying to name these variants of concern. Alpha was the one that was first described in the UK. That's known as B117. The Delta variant was the one first described in India. So there's Kappa and Delta, two subtypes of 617. And so these look like they're more transmissible. They may also be more cause greater severity of illness. So the Delta variant is the one that you may have been hearing about earlier. And there's a number of viral naming conventions, and I think they're trying to go for something that's easier for people to get their heads around.
Okay, thank you for that. Dr. Auwaerter, what is the ideal time to initiate remdesivir treatment?
Well, I think here it's not exactly clear for an ideal time. The FDA has approved it for any hospitalized patient. There could be someone not on oxygen who's severely immunosuppressed that it may be appropriate to start it on, just because they may not have a good immune system. On the other hand, the studies would suggest that if someone's admitted and looks like they need oxygen, that would be the time you'd want to start. So earlier is always better for antivirals. The reason not everyone that should get it, for example, even if they don't have oxygen needs, could be that so many people just get better on their own. So the trials would have to probably treat many, many people to show benefit for that group, and we just don't have that at this time. Okay,
and I think we'll wrap up here with this question. Is there any value to antibody testing after vaccination? So a patient was negative for antibodies per an approved test 2 months after the second vaccine dose.
Yeah, so that's an excellent question. I think on many of our minds, patients would like to know, do they have a meaningful response? And part of the issue is the antibody tests for spike proteins are not broadly standardized, so it's hard to compare or understand. Obviously, if someone is absent anti-spike antibodies, and make sure you're getting the anti-spike test, not the anti-nucleoprotein test, which is another very common antibody test for SARS-CoV-2. if they're negative, even weeks after your second immunization, that would probably be disheartening. We don't yet know if you don't have some protection from that. I think people are trying to understand if additional boosters are worthwhile. Should they get a different type of vaccine? So it's unknown. Personally, I think for certain patients, if they'd like to know, I've been ordering the test because if they don't have a detectable antibody response, I tell them they should continue to be cautious if we still have high community rates of COVID-19.
Great, and thank you again for answering all of those very, very good salient questions from our audience. So just a reminder to anybody watching still, if you'd like to claim credit, please click on the claim credit button. It'll appear when the webcast ends, and be on the lookout for our 30-day survey. You will receive that through email. As always, your responses will help us develop further education, and we thank you for joining us. Have a great day. Dr. Auwaerter, thank you so much.
Thank you, and thank you so much for joining, and hope all